Presenting this great case of question of transposition of peroneal tendons. We've got a 50-year-old female with chronic pain. Question about transpositions. What about pes cavus? Let's take it to Collective Minds Radiology, where we can see our great de-identified images, our mobile PACS, and get our conversation going. I've already started to look at the angles. I wanted to dig right in, and right away I'm getting a measurement of the calcaneal pitch angle from the base of the fifth to the calcaneus to the calcaneocuboid, coming into a normal range. One thing I'm going to look at next, I would like to understand whether or not I have cubonavicular coverage. I'm going to zoom in a little bit so that we can all appreciate what I'm measuring. And essentially, we want to get the articular surface of the cuboid and understand where the undersurface of the navicula lands. And we want it to be about 50%, so there's a perfect amount of naviculocuboid coverage to give us the relatively normal arch. When we look at Mary's line, very important line, we're going to understand from the lateral talar process to the dome, bisect, and now you have to decide where you're going to drop your line. You want to understand around 50% of this. So when we draw our line around 50%, let's see if it bisects where we want our first metatarsal axis to be. And it does such a great job. It's really on a line. So our lateral angles are panning out, and we can also use the Cobb angle to help us see the lateral talocalcaneal angle. We can use the same vector, and of course what we're looking at in this case is 33 degrees, and that is within normal limits for a patient. Over 45 degrees would be considered hindfoot valgus, and less than 20 may indicate a patient with hindfoot varus. Let's move on to a frontal image. Now we're on the left, so let's bring up the left. And what we can do in this image is we can appreciate the first metatarsal talar axis, or the talar first metatarsal axis. Looking at the talar head, we want to understand where we would get the bisection of the articular surface and draw a perpendicular line to that. We can see we're still on the Cobb angle, but essentially the fact is that the bisection of this interpretation of the articular surface is medial to the hallux, which shows in patients who overpronate or have more likely to have pes planus. So our numbers so far, we're either normal with a slight medial deviation of the talus, medial to the hallux, and a patient would be more likely to have pes planus. So let's take a look at some other features. We can appreciate the sesamoid axis. If we look at the bisecting the first metatarsal, notice that the tibial sesamoid is approaching into stage 1 position once it gets to 50%, and past midline is a stage 3. So we're beginning to have some sesamoid rotation, which tells us a little bit about the need to pronate or the overpronation biomechanics that might be in this patient. Looking at the midfoot, we can see that there's some degree of overlap at the metatarsal bases. When I see the third metatarsal base overlap greater than 50% on either side from the base, I think about moving towards forefoot inversion. Eversion is the opposite, where we see the metatarsal bases very well. So there's some forefoot inversion compensation here. A little bit of subchondral sclerosis we can appreciate. On the coronal film, now we can see a symmetric ankle mortise. Let's zoom in a little bit more on that. And I don't often use the hindfoot alignment type of projections to figure out hindfoot varus or valgus. I do tend to use the AP, if I'm to use the Cobb angle. If I was to look at the AP talocalcaneal angle, I would be looking here. And again, less than 20 is something that we see in varus, and greater than 45 is something that we'll see in valgus as the calcaneus moves away. This is on the right foot, moving to the left foot because both of them are loaded here. We can appreciate on this side the AP talocalcaneal angle, and that's all based on the fact that they are staying in this nice position and the tube angle is maintained proper, and that allows us to draw conclusions on these types of measurements. But what I'm looking at, if I'm to bisect the talus again and that's a better guesstimate of this line, and so now I can appreciate that I have more of a varus type of heel on the left. So it's an interesting biomechanic. I'm doing some rear foot varus, some forefoot inversion, slight rotation of the hallux into, lastly, we can look at something like the hallux valgus angle or the hallux abductovalgus angle. and just reposition that. Where about a 9-degree angle is considered normal, 9 to 15 mild, 15 to 25 moderate. And when you see where we are here, we're basically 17 degrees. We're just above mild hallux valgus with that mild sesamoid rotation. So that's a very in-depth look of how we can evaluate x-rays, looking at all sorts of angles, and we see that it's almost normalized here. So let's take a look at the MRI and see what are the features in this case. So looking at just rolling through the images, we can see right away that we have a bone marrow edema at the medial retromalleolar groove. We have some enlargement of the posterior tibial tendon and tenosynovitis of the medial flexor tendons to the master knot of Henry, and sprain of the medial flexor retinaculum. Let's move to the lateral flexor tendons. We can see that peroneus brevis has tendinosis, longus also tendinosis. We do see that the superior peroneal retinaculum is stretching and that there's fluid making its way through a small gap, and the peroneus brevis is actually sliding into that gap here, slightly subluxing off of the lateral malleolar groove. Inframalleolar continues this split tear to the point where it's still split to the base of the fifth, and we can look at that on coronal imaging as well and see it also. You're seeing the swelling here, and you want to keep looking at it in multiple projections to train your eye. But I'm looking at the two pieces of the peroneus brevis, the longest in the middle. The brevis will come back, never quite makes it back together. Again, we can see that the two portions of the peroneus brevis. Moving back to the axial images and appreciating the superior peroneal retinaculum and the tenosynovitis distally and the peroneus longus. Now we're ready to take a look at the irregularity of the tendon. This still hasn't thinned, so I would call this just tendinosis. And of course, I'd like to look at that on several images to make sure I can see that distal tunnel. And don't forget there's magic angle that afflicts these as they move at 55 degrees to the main magnetic field. Moving on from the peroneal tendons, don't forget your extensors. I'm seeing just a slight amount of tenosynovitis at the proximal tibialis anterior. Otherwise, these guys are looking okay. Let's go to the deltoid. I see mild sprain of the deep deltoid, superficial deltoid tibiospring, minimally thickened. I'm seeing minimally thickened spring ligament with periligamentous edema. And let's take a look at the inferior and the medial plantar bands on another sequence so that we can appreciate the tibiospring to spring ligament and the mild sprain. So all subacute mild sprains that are going on with the deep deltoid, superficial deltoid, and spring. Let's go to the lateral cladal ligament complex. Our syndesmosis, nice posterior, anterior, interosseous ligament region, not widened, probably around 2 millimeter. ATFL we're seeing as this minimally thickened, slightly wavy sprain with periligamentous edema. PTFL, this looks like thickened, mild synovitis, not too much. Again, I like to take a look at that and compare that to T1, always training my eye. I see this as mild chronic synovitis with changes on the inner aspect of the distal fibula that have been described in patients who have posterolateral ankle impingement. Calcaneofibular ligament we see here. Let's take a look now. This other guy here is your lateral talocalcaneal ligament. Let's take a look at that on the coronal images. Moving from the lateral talar process where it attaches and moving posteriorly, as you can see, as it gets back there. It's hard to follow the whole of it. I feel that I'm still practicing in different ways, but at least I now can identify that there is this lateral talocalcaneal ligament. Now, the calcaneofibular ligament, I'm seeing some part of it here to here to here, and that's the calcaneofibular ligament. So the talocalcaneal ligament is this structure here that moves posteriorly, and then I think it might be that superior band here. Yeah. So moving from those ligaments and the sprain of those ligaments, let me just get back to, so I would call this ATFL sprain, partial tear, periligamentous edema, that's subacute on chronic. PTFL, subacute on chronic, calcaneofibular ligament, and lateral talocalcaneal ligament, subacute on chronic with synovitis. Now let's get to the ropes. Let's do your Achilles, mild tendinosis, peritendinitis, no large Haglund deformity, plantar fascia, central cord thickening, periapneurotic edema. Let's make sure we assess for the presence of muscular atrophy. This is questionable. There is mild atrophy in some of these muscles. Let's take a look on the axial images and see if we can see in the forefoot a bit. Still not sure if this person truly has neuropathy. Of course, I'd check it anyway, but this is equivocal to me. Moving back to the bony structures now, let's take a look at, we have subacute bone marrow edema, subacute to chronic marrow edema of the medial malleolus. We had that retromalleolar groove edema here, further stress response, and in terms of the vector of this person on a T1 weighted image, notice if I'm to look at the, where I think that the real articular surface goes, it moves along our x-ray. These trabecular lines of stress are what the body has to do to get this person to have a biomechanical forward motion. Looking at the posterior talar dome, which I can't see very well on this, so I'm going to go to my sagittal and see what we're missing. Probably just a little bit of edema, tibiotalar mild edema, and what I have is a relatively normal arched foot. There are some dysplastic features to the talus. There is some curvature to the articulations. None of them are severely degenerative. I would not have called a coalition in this case. And that's it. So in the impression altogether, what I have is hypertrophic PT tendinosis, medial flexor tenosynovitis, and stress-related edema medial malleolus. We have peroneus brevis split tear, superior peroneal retinacular tear, and lateral synovitis. This feature here is more closely linked to being in a pes cavus or a cavus varus situation. So those features that we saw in the x-ray may be mixed biomechanic in this person, but nonetheless they have these features of peroneal tendon tears. That this here is not an acute tear, this is a subacute on chronic type of injury. One thing we didn't talk about is the sinus tarsia, this partial preservation of the fat. So getting back to the after the medial flexors, hypertrophic PT, peroneus brevis split, SPR tear, lateral collateral ligament complex, subacute on chronic, grade 1 to 2 sprains. I would say grade 1, that they're thickened with periligaments edema, and deltoid, same story there. Grade 1, subacute on chronic with some thickening and periligaments edema. And that is a wrap. Thank you.